So I'd like to invite everyone to the PSMA for Diagnostics and Treatment session. I'm chair and Matthew Smith is co-chair, and we're going to hear from our first presenter now, Ken Herrmann, talking about PSMA PET state-of-the-art.
So thank you, Louise. So Karim Fizazi said yesterday that this is his most favorite prostate cancer meeting. And I want to echo this, so thank you, Silke and Aurelius, for organizing this. To see the actually biggest accomplishment of our field, you just have to see the first slide, because for the first time we see at APCCC PSMA radioligand therapy in state-of-the-art in one sentence. And the reason we have achieved this is actually that, first of all, we have a product now, which is FDA and EMA approved, and the second thing is we have a couple of phase 3 studies which have at least completed recruitment. These are my disclosures. I will very quickly remind you what Diagnostics is, then I will talk about PSMA radioligand therapy today, tomorrow, and discuss with you potentially challenges if the cowbell doesn't ring. The idea of Diagnostics is that we have a very specific receptor which is overexpressed almost exclusively by tumor cells, or at least in a favorable ratio between tumor cells and background. Then we identify a ligand which binds with a very high specificity to this receptor, and all we have to do then is actually to label it with a linker or a chelator with a diagnostic or therapeutic radionuclide. And here two quick examples, either using beta emitters or alpha emitters for therapy, or on the left side for imaging and SPECT or PET emitter. Talking about radioligand therapy today, we need to talk about the VISION trial. The VISION trial was a very pragmatic study investigating lutetium PSMA radioligand therapy in a third line and later in mCRPC. Patient had at least one novel endoandrogen and one or two taxane regimens. Then standard of care was decided, excluding a number of options like chemotherapy, immunotherapy, radium-223. And once this was the case, patients were randomized into standard of care or into standard of care plus 4 cycles of lutetium PSMA 617, which could be increased to 6. Primary endpoint was rPFS and OS. And just by looking at the curves, you can very nicely see that indeed the blue curves, which is standard of care plus PSMA, is significantly better both for OS as well as for rPFS. In line with OS and rPFS, we also see an advantage regarding the quality of life criteria. This was published last year in Lancet Oncology, again underlining the high effectivity of this treatment. Toxicity is important to look at. We look very quickly at the grade 3 and 5 toxicities between standard of care and standard of care plus lutetium 617. We do see an increased toxicity in the bone marrow suppression area, mainly lymphopenia, anemia, and thrombocytopenia. Quite interesting, we don't see a difference regarding dry mouth and renal effects between standard of care and standard of care plus lutetium. Looking at lutetium PSMA and the way to its approval, we also have to mention quickly the therapy trial. It's an investigator-led initiative from Australia, randomizing in third-line mCRPC patients into cabazitaxel and lutetium PSMA. Interestingly, one of the first trials doing adaptive dosing, reducing the activity over time. The PFS curves are on the right. You see that the curves cross in the middle. Then there's a certain significant advantage towards rPFS, but not surprisingly, the OS curves are not significantly different. The take-home message from this trial was actually that both of these treatments are very efficient. We will hear a little bit more from Tom Hope later about how to select patients for therapy. I'm going to skip that here. As a reminder, where do we see PSMA radioligand therapy now in the guidelines? Both EAU and ASCO as well as NCN actually mention the recommendation of PSMA radioligand therapy in the VISION label, which means patients mCRPC must have seen one novel endoandrogen and one taxane chemotherapy, and they should undergo PSMA PET for selection. This is an overview on how many PSMA-directed radioligand therapies are currently in clinical translation. And you can see the number of different trials, including different radionuclides, but so far only one compound, the PSMA 617, is EMA and FDA approved. Looking into the future, on the left side, on the top, we see PSMA addition trial, a very interesting trial. We try to combine lutetium PSMA in addition to standard of care in the hormone-sensitive setting. This study has finished recruitment, and we are going to hopefully see a readout around 2026, 2027. On the bottom, the SPLASH study, which tries to actually move PSMA ligand therapy into the pre-chemo setting in mCRPC. A very similar study is actually the PSMA-4 study, which I show a little bit more about it. Very important here, the primary endpoint was successfully reached, which was rPFS. On the right side, 2 IITs, which are really a little bit more ambitious, trying to bring PSMA ligand therapy in the pre-postectomy setting. On the top, the IIT from Peter Mack, published in European Urology recently, the lutectomy trial with Reno Ipme as the first author, establishing that lutetium PSMA is actually safe prior to prostatectomy. Patients underwent 1 or 2 cycles of lutetium PSMA. And as a consequence, the trial on the bottom, it's an EP trial, also an IIT, and here's the idea actually to combine lutetium PSMA plus ipilimumab in 2 cycles prior to prostatectomy, and here the hope is to also see a couple of complete remissions. PSMA-4 is a very important study because it's really a prospective phase 3 study investigating PSMA, lutetium PSMA in the pre-chemo setting. Here, patients who have progressed to an ARPI are randomized in either ARPI switch or lutetium PSMA 6 cycles. Primary endpoint was RPFS, and a crossover was allowed. The RPFS data was shown ESMO 2023, I think quite convincing. Median RPFS was 12 months compared to 5.6 months, statistically significant, so this was very nice. A little bit surprising maybe in the beginning was that the overall survival curves look like that. You see on the left side the crossover adjusted analysis, on the right side the intent to treat analysis. From the curves you can see they were not statistically significantly different. On top of this, you also can see that the hazard ratio for the intent to treat analysis was actually 1.16. Again, high crossover, 84% of patients actually switched from the ARPI switch over to lutetium PSMA. Quality of life on the left side is going in the direction to favor lutetium PSMA. We already reached statistical significance, as you can see. On the right side, the toxicity profile, quite interesting. If you look at grade 3 and 5 toxicities, we see in both arms anemia with the same frequency. Apart from this, we don't see anything which hints towards the direction which is not favorable for lutetium PSMA. And now something very recently, I think this is just a little press release, not much details given, but apparently at the 75% event readout, the intent to treat analysis has now a hazard ratio below 1.0, which potentially for all of us clinically doesn't make so much difference, but might have huge implications regarding the regulatory approval. A super interesting trial is ENSA-P study. The ENSA-P study tries to combine enzalutamide with lutetium PSMA. These are patients in mCRPC chemo naive. Louise, Emmett, the first author, recently published in Lancet Oncology. The interesting part is patients were selected when they had at least 2 high-risk features for early enzalutamide failure. Patients were then randomized 1-to-1 into ENSA versus ENSA plus lutetium PSMA. You can also see one of the first trials implementing the option to really stop lutetium PSMA along the way. Primary endpoint was PSA-PFS, statistically significant, 8 months versus 13 months. For me personally, even more impressive if you look at the PSA90 reduction rates, 78% for the combination versus 37% for enzalutamide alone. This being said, if we talk about the VISION trial, you remember Bertrand Tombal told us yesterday the most important things you find actually in supplements. You will actually see that in the standard of care, more than 50% of patients had an ARPI. And if you look even a little bit deeper, you can even find out that the patients who had a combination of lutetium PSMA with ARPI are the ones who actually responded the best. Now, very quickly, talking about challenges. A very important one is the response assessment. This is one of my most favorite slides. The reason is you can see that patients, same group of patients, are going to lutetium PSMA therapy, are judged to have progressive disease, yes or not, and the rate ranges between 13 to 58%, depending on what response classification you use. This is absolutely not acceptable. For us as a community, we need to come up with a solution and to standardize this. And one of these concepts actually is the COPRA project, initially called COPRA project, the Comprehensive PSMA PET Reporting Recommendation. The aim is to standardize the way we report PSMA PET, hopefully also the way we actually assess response in PSMA PET, using PSMA PET in prostate cancer. Recently, it was renamed to SPARK. We made quite some progress here at APCCC, so I'm quite confident that later the year you will hear from this and have a couple of our conclusions available. In summary, to kick off the session, last session of today, diagnostics involving radionuclides is ready for prime time. VISION clearly paved the way to establish PSMA ligand therapy as a volume indication. The next steps will be moving PSMA into earlier lines. Overall, PSMA ligand therapy or ligand therapy at all is an opportunity to establish a new platform technology outside of PSMA, but also outside of prostate cancer. We have a couple of very important challenges to address. Therapy monitoring and the way we report therapy monitoring is one of them, and I really hope that in February we might already provide some first answers to that. Thank you.
Thank you. Our next speaker is Thomas Hope. He'll discuss patient selection for radioligand therapy, how to do it in clinical practice, and how to decide on the number of cycles.
Great, thank you. And my biggest weakness as a speaker is speaking too quickly, and the cowbell has me scared, especially after Ken ended a minute early, which by far is probably the best performance of the week. So thank you very much. So I'm not going to read this title because it's too long. Here are my disclosures. So let's start with how we use PSMA PET for patient selection. So here's a patient, SUV max is 30.8. There's two sort of major criteria we've used in the literature to select patients. One's the vision criteria, right, where you have uptake greater than the liver in measurable disease. That resulted in 13% of screen failure rate. The PSA 50 in that trial was 46%. The other criteria that was used was Mike Hofman's therapy. In that trial, they used a higher criterion, SUV max over 20. So in the hottest lesion, you had to have an SUV max over 20, which is maybe 4 to 5 times higher than the requirement in vision. The liver is usually about maybe, let's say, an SUV mean of 4 to 5, something like that. And that resulted in a higher screen failure rate of 31%. Of note in therapy, they also acquired FDG PETs and excluded patients based on mismatch as well. So by excluding that additional, let's say, 18% of patients, the PSA 50 went up to 65%, indicating that, if you get rid of the patients with lower uptake, you actually end up with a better outcome in the patient population, not too surprisingly. Now, what does uptake mean? So this is a post hoc analysis. It's actually prospectively defined in the protocol of vision, showing the RPFS and OS broken down by SUV mean quartiles. Now, very conveniently, the quartiles in vision ended up being the top quartile being an SUV mean of 9.9, nearly equivalent to what was done in the next slide in therapy. And you'll note here that if you're in terms of OS, that blue line, right, that's the top quartile, those patients do by far the best, right? They really outperform. So the patients who have highest uptake do better, and then the other 3 quartiles actually behave relatively similarly. Interesting. There doesn't seem to be much impact of uptake in those quartiles in OS. And this here, just for comparison purposes, is the OS in the control arm. So if you didn't have that top quartile, vision actually would have been negative, right? So uptake here is important. The top quartile does the best. Here's the same thing in the therapy trial, showing again that if you have an SUV mean over 10, you do much better overall. One thing I think we don't talk about much here is that SUV or uptake on a PSMA PET is not just predictive, that patients do better with PSMA radioligand therapy versus cabazitaxel if you have higher uptake. It's actually prognostic, right? If you look in that cabazitaxel arm, you actually do better if you have higher SUV mean as well. So these people with higher uptake actually are just better actors overall, and you also have some predictive value there in terms of response to PSMA radioligand therapy. So I broke this down and calculated out the percent of patients who have an SU mean of 10 between vision and therapy. And I found it interesting, it was the exact same rate between the two trials, exactly 22% in vision and therapy who had an SUV mean greater than 10. You just, on the left side there, you have a different screen failure rate. Now, overall here, I don't know where the SUV max of 20 fits in there because the gap between vision and therapy included a higher SUV mean, but also this mismatch with FDG PET. But I like to call this here the vision therapy gap, right? And how do you think about patients in that gap? Are they good candidates for PSMA radioligand therapy? Should we not be treating them? How do we think about it? So at UCSF, we went back and looked at our patients, and we actually found that in what I would consider the vision therapy gap, of note, we didn't do FDG PET, so it's not really a fair definition there, but they had a PSA 50 of 39% if you didn't have an SUV max up to 20. So they actually benefit from therapy. So even on the lower end of the spectrum, people are benefiting from receiving PSMA radioligand therapy. So it's really important not to get stuck on this SUV mean of 10 being used for patient selection. They do really well, but you shouldn't exclude anything below that for that reason. Now, what's the role of FDG PET? I'm going to get Professor Hofman here a little annoyed. You can use FDG PET to find PSMA negative disease, and clearly on the right there's a really beautiful chart showing that if you screen fail in therapy, you do really bad, right? Those are bad actors. Those patients would do bad probably in any therapy you administer to them. So FDG PET can find these bad actors. Now, here's an example of a patient with a FDG positive PSMA negative disease. We didn't do an FDG PET because it's pretty clear that there's going to be a mismatch, right? You have big, bulky hepatic disease. You're going to know that that's PSMA negative. I don't need an FDG PET. And actually, Professor Herrmann's group did this paper, and Professor Sir Dr. Seifert's in the audience somewhere here, I saw him yesterday, showed that only 3% of patients did you catch with PSMA negative FDG positive disease by actually getting an FDG PET. So it's not really clear that we need FDG PET to screen all patients. There's probably a couple of patients there that you're worried about that you might need to get an FDG PET, but as a general rule or recommendation, I wouldn't recommend getting an FDG PET across all patients. Last comment, I was asked to talk about nomograms. So there's one nomogram out there by Andre Gafita looking at predicting the response to PSMA radioligand therapy. It sort of works, maybe. There's some accuracy there. It has no role in clinical practice. You shouldn't use this to determine whether or not you should treat patients. And you can see even in this trial where they retrospectively applied this nomogram to see in the therapy trial if it predicted response. You still have 3 patients who had a PSA response of over 80% in the patients who were predicted not to respond to PSMA radioligand therapy. So overall, patients for PSMA RLTV should be selected based on uptake greater than liver. SUV mean greater than 10 and nomograms is not really relevant for clinical decisions in our current patient populations. As you go earlier in the course of disease, uptake may become more relevant. In the post-chemotherapy setting, obviously, we should be giving the opportunity to the patients to receive this drug as much as possible. Now, how to determine when to delay or stop treatment. Now, I'm going to focus on patient response in PSA imaging, and Louise, Professor Emmett's going to talk about hematologic issues, et cetera, after me. So here's an example of a man. You get a PSMA PET at baseline, SU max is 24. These are post-treatment specs. I'm going to spend the rest of this talk, in essence, talking about post-treatment specs. So you can image patients after each cycle, imaging the lutetium itself. Lutetium emits gamma photons. You can actually create an image of the therapy and track patients over time without having to do a PSMA PET. So you can see after each treatment here, cycle 1, cycle 2, cycle 3, what's going on with their disease. At cycle 2, you can see maybe a little bit of increased disease around this pelvic metastasis. The PSA is going up a bit, and then clearly at cycle 3, that patient has clearly progressed with multiple new osseous metastases that wasn't present at baseline. So you can use this post-treatment imaging to track response to therapy and determine when you should stop early. So we stopped after cycle 3 based on the PSA and post-treatment imaging. And there you can see the disease in the chest responding well. Okay, now Dr. Emmett's also done a lot of work looking at these post-treatment SPECT scans and changes in tumor volume. So if you respond, your tumor goes down, your PSA goes down, you do much better. Not too surprising, right? So it's prognostic, right? If you have a decrease in uptake, you're going to have a better overall survival overall. And then Professor Emmett took it another level. Okay, if you have a good response and your PSA goes down, then we can start instituting treatment delays, right? So we can actually spread out the doses. And so here, that blue arm is this response group 1, people who are responding well. They actually had treatment delays. They had improved overall survival overall, showing that you can actually now use this post-treatment SPECT to impact the management of our patients. So here's another example at our institution. Patient had an SU max of 61, someone you'd think would do very well. You can see at cycle 2, we actually have a heterogeneous response. The green arrows there are showing disease is getting smaller. Red arrows are showing disease is getting worse. We, again, in this patient went on to cycle 3. You could see he started to declare at cycle 3 that he was truly progressing, and we stopped at that point in time. We went back at UCSF and looked in our first 122 patients we treated to see how often these post-treatment SPECTs impacted management. And you can see here that 49% of patients who received PSMA radioligand therapy had their management changed based on the post-treatment SPECT. And I think the important thing here is that the change in management didn't just happen after cycle 2. And I bring that up because there's a lot of focus on using PSMA PET as a response assessment, particularly after cycle 2. But you really only get one PSMA PET, right? You got to choose where you're going to acquire that. And these patients progress or respond at different points in their treatment cycles. And so post-treatment SPECT, in my mind, is a much better way to evaluate response and manage patients rather than using PSMA PET. So here's one last comment. Another patient, you can see 2 post-treatment SPECTs showing stable disease. But in this case, you can see the patient developed a PSMA negative nodal metastasis, and this is obviously indicative elsewhere in the disease. You also got to get your conventional imaging to make sure you're not missing the development of PSMA negative disease. So repeat imaging, preferably with post-treatment SPECT, should be performed to evaluate PSMA uptake. A lot of people are using PSMA PET-CT, but I think SPECT-CT, it's cheaper, more readily available, and can be done after every individual cycle. Don't forget, conventional imaging also needs to be performed to exclude the development of PSMA negative disease. So in conclusion, we should use uptake greater than the liver on PSMA PET to select patients for PSMA radioligand therapy. SUV mean and nomograms should not be used to determine if a patient is a candidate for PSMA RLT. Okay, my mantra is every patient deserves 2 cycles. Okay, you can tell how they're responding within 6 weeks and determine if you want to keep on doing treatment or move on to another therapy. FDG PET should be saved for difficult circumstances, shouldn't be routinely used to screen patients. And lastly, post-treatment SPECT should be used to follow patients, and this is sort of trying to push us away from relying on PSMA PET as a response evaluation in the setting of PSMA RLT, because we have, in essence, our SPECT PSMA images that are replicating that but can be done after every individual cycle. So thank you very much.
Thank you. Our next speaker is Louise Emmett. Louise will discuss dosing of radioligand therapy in special situations and/or toxicity. Louise?
Thanks so much for asking me to talk today. It's such a pleasure to be at this conference. I'm going to talk about dosing of radioligand therapy in special situations and/or toxicity. I'm really going to concentrate on lutetium PSMA. My special situation is going to be high volume disease, and I want to talk about marrow compromise and renal toxicity. And I'm not finding the way to change this slide. Oh, here it is. Sorry. So these are my disclosures. We, at the moment in the prospective trials, unsurprisingly, we have very conservative inclusion criteria for marrow, and we also have very conservative dose reductions of 20% for marrow dose-limiting toxicities with dose delays inbuilt for platelet reduction with lutetium PSMA. Super scans were actually excluded in the VISION trial, and the question is, can we safely treat outside of these parameters? So when we look at the exposure-adjusted treatment of emergent adverse events in the VISION trial, a lot of patients had grade 1-2 marrow compromise. 16.7% of patients had greater than grade 3 anemia. 10% of patients had greater than grade 3 thrombocythemia. Neutropenia was uncommon, and acute kidney injury was also uncommon as a grade 3 event on VISION. So looking at this exclusion of patients with diffuse marrow involvement, can we safely treat them? So this is a multi-centre retrospective study that looked at 43 patients who had diffuse marrow involvement. They received a median of 4 cycles. They got a very respectable 58% PSA 50% response rate. Time to pain progression was 8.3 months. And they had grade 3 anemia that was higher but similar to VISION, 22% versus 16.7% for anemia, and thrombocythemia 17% versus 10%. So it does look like we can safely treat these patients, and probably that we should treat these patients. But I really want to talk about marrow compromise and dose reduction and separate marrow compromise before we commence lutetium PSMA due to large volume marrow disease, and marrow compromise after we commence lutetium PSMA, because I think they should be treated differently. When I talk to my junior staff at the hospital, I say that we actually have to focus on getting habitat back for our marrow. If we have very large volume disease, prostate cancer cells in marrow, we need to give a high enough dose so that we actually have a place for those marrow cells to come back to. If we don't give a high enough dose, we just don't achieve that. And the question is, how high can we go? If we look at these two images here, the low volume image and the high volume image, and you look at their salivary glands, what you can see is this quite intense salivary gland activity with the low volume image. You can almost not see them with the high volume image. At the moment, we're giving a standard 7.4 gigabecquerels, which is based on external beam dose constraints to the kidneys. But we actually get a dilution effect in patients with high volume disease. If you look at an individual cellular level, the radiation dose to each of those cells in high volume disease would be much lower than it is in low volume disease. Can we change that? So there was a very nice study by Scott Tagawa and colleagues that was a dose fractionation, dose escalation study. 56 men, they fractionated the dose of lutetium PSMA day 1 and day 15 to men to receive up to a total 22 gigabecquerels over that 2-week period. No PSMA PET for inclusion criteria. In the patients who received, so 27 patients received a total of 22 gigs, there was a 54% PSA 50% response rate. Median PSA PFS with these 2 doses only was 5.6 months, so longer than therapy. RPFS was 9.6 months, longer than VISION, and adverse events were similar to the trials that have been undertaken, which incorporated 6 doses. Multivariable analysis of this study showed that it was actually the increased dose and increased PSMA expression correlated most to overall survival. We channeled that a little bit clinically in this patient. He's a 48-year-old patient, 10-year-old child, uncontrolled pain, metastatic castrate-resistant prostate cancer, failed all treatments. And we fractionated 9 gigs, dose 1, and you can see the lutetium SPECT, dose 1 on top, and 9 gigs 2 weeks later, Dose 2. This patient had a PSA drop from 90 down to 10, came off all pain relief, hemoglobin increased from 88 to 124, and improved energy. So should we consider this in our patients? Certainly not all patients with high volume disease, even with a higher dose, will do the same. Heterogeneity, and that's really what's also measured with SUV mean, predicts response. And this is a clinical response criteria using a binary heterogeneity visual score. Patients with heterogeneous disease do much more poorly than patients with homogeneous disease. So this patient with bright uniform disease on the left, we would definitely treat, and we would expect them to get a good treatment response. Both these patients are eligible on vision criteria, but the patient on the right has highly heterogeneous disease. It's not particularly bright in marrow. If we treat them with lutetium, we're very likely going to get grade 1-2 anemia from marrow plus disease progression, and that patient's at high risk of marrow compromise. I would not treat that patient. Looking at marrow compromise after commencing lutetium PSMA, I think this is a good example. This is a patient on a clinical trial who had a slowly rising PSA between dose 1 and dose 4, 40 up to 80, but quite precipitous marrow compromise at dose 4, hemoglobin 80, platelets 89. The question was, should this patient have a marrow trophine to see if it was lutetium toxicity? And they don't really need that. If you look at the SPECT imaging done after each dose, you can see increasing volume of disease. And in fact, you can see that the patient now has total involvement of most of their marrow. They've got filling in of the bone. So it looks like a bone scan now rather than PSMA PET scan. On imaging and on PSA, this patient has unequivocal disease progression. That is what's causing the marrow failure. They don't need a dose reduction. They don't need a marrow trophine. They need to change treatment. And it probably would have been better for them to have changed treatment based on the SPECT and the PSA images before they went into marrow failure. We need to learn to use multiple biomarkers. So renal toxicity with lutetium PSMA. We don't have a lot of information in the prospective trials. Most patients are very end stage and they don't survive long enough for us to get good information on long-term toxicity related to renal. This is a retrospective study of 106 patients from Germany who received a minimum 4 doses and found that the eGFR actually decreases fairly progressively in most patients. There's a median 13.6% drop in eGFR at 12 months, and in the 20% of patients who made it to 24 months, a 20% drop in eGFR. Risk factors for drop in eGFR were hypertension, diabetes, age, and prior taxane chemotherapy. If you have compromise of GFR at the beginning, can you treat them? So this is a nice study by Samir Ezzedine and colleagues, 22 patients, half of whom received 6 cycles of lutetium PSMA and had a median GFR of 45 mils per minute. They found that in fact in this group of patients there was an increase in GFR with treatment and they found no significant reduction in GFR at follow-up assessments and no correlation between change in GFR and per cycle treatment. This is one of the patients from that trial who had an increase in GFR. Very likely they had GFR compromise due to ureteral obstruction due to nodal involvement which got treated with the lutetium PSMA. This is another case by Mike Hofman and team from Peter McCallum showing a patient with an eGFR of 17 mils per minute, went up to 24 mils per minute with stenting of their kidney, who went on to receive 4 doses of lutetium PSMA without GFR compromise. So it does look like we can treat patients with impaired renal function up front, but we will have problems in long term with most patients in the long term. So delayed toxicity, what do we know? Long-term kidney dysfunction, it could be ligand dependent, it might be related to INT, might be less with 617, we don't know. And myelodysplasia is the elephant in the room. Are we going to get a lot of myelodysplasia with these patients? Possibly. It's something that we need to measure, but there's no data on it at the moment. We're going to get a lot of information from this in PSMA4, PSM addition, in SPLASH and ECLIPSE, and I hope that we can look at toxicity in all these trials very carefully. One thing to say is that adaptive dosing, as we move lutetium PSMA and PSMA targeted radioligand therapy earlier in the prostate cancer space where people are going to be living longer, we need to think about doing adaptive dosing. With ENZA-P, what we did was we did an interim PSMA PET and decided if there was no persistent target to stop treatment at that stage. And I'll just point out here that the PET and the SPECT look very similar, week 6, and PET at week 12. Perhaps we can use SPECT instead of PET. In patients who did have a persistent target, they got the full cohort of doses. This can help us delay or reduce radiation dose in patients who actually don't need it, and possibly help with long-term toxicity. So in summary, marotoxicity grade 2, 1 to 2 is common with PSMA-targeted radionuclide therapy, but if we dose reduce at the first dose, we may actually exacerbate marrow failure, and I really have to question whether we're treating our patients with high-volume disease adequately. Severe marotoxicity related to lutetium most of the time is due to disease progression, and we have to learn how to look for it better using composite biomarkers, PSA and SPECT. Renal toxicity is not a short-term issue, but we need better evaluation in our prospective trials that are already underway to see if it's a long-term issue, particularly as we move radionuclide therapy earlier in the space, and we need to define them. They've not yet been defined what the real risk of renal toxicity and myelodysplasia will be. Thank you. Now I'd like to introduce Matt Smith, who is going to talk on prostate cancer. Yes, who should receive chemotherapy before PSMA radioligand therapy?
Good morning. Let me begin by saying that there's very limited information about the comparative effectiveness of taxanes and PSMA-RLT, and the optimal sequencing of these agents remains undefined. So how can I address this very challenging question of who should receive chemotherapy before PSMA radioligand therapy, or for that matter, the converse question? So my approach would be to briefly review the evidence supporting use of these agents, to do some cross-trial comparisons of available evidence, recognizing that there are major limitations of that approach, and then to comment again on therapy, this very important randomized phase 2 study that you've already heard about. So it's worth noting that docetaxel was approved based on 2 studies that were reported 20 years ago. In TAX 327 and SWOG 9916, there was a survival benefit for docetaxel compared to the control arm of mitoxantrone. We should not be too nostalgic about these results, though, because it is unknown whether docetaxel retains a survival benefit in a contemporary era of effective ARPIs. We do know, though, that the response rates to docetaxel fall off in patients who've had progression despite a prior ARPI. In the PRESIDE study of patients with progression on enzalutamide in MCRPC, for example, the response rate to docetaxel, PSA response rate was only 25% compared to the 45 to 50% PSA response rates previously reported in TAX 327 and SWOG 9916. Cabazitaxel improved survival in MCRPC. In the TROPIC study, it beat mitoxantrone in patients who had disease progression on prior docetaxel. And in the CARD study of patients with progression despite prior docetaxel and an ARPI, cabazitaxel improved survival compared to the AR pathway inhibitor switch. You've seen this data, vision improved survival in a similar setting to the CARD patient population post-ARPI and taxane with a hazard ratio of 0.62. In contrast to vision, PSMA-4 was not well designed to show a survival benefit by allowing crossover, and as you've heard many times, there was a high rate of crossover observed. And in the second interim analysis for overall survival, the hazard ratio is 1.16. So not only not showing a survival benefit, but raising a concern that there could actually be a survival disadvantage to administering PSMA radioligand therapy earlier. That concern has been allayed somewhat by this update, with now 75% of the required events for the final analysis reporting that the hazard ratio is below 1. We all await longer follow-up to determine whether there's actually a survival benefit to earlier administration of PSMA lutetium. So this is, again, so why this discordance? I think the attribution of the high rate of crossover is probably correct because other intermediate endpoints appear remarkably similar between PSMA and vision, with similar impact on progression, RPFS, similar objective response rates, and similar PSA responses. So now let's do some cross-trial comparisons between chemotherapy and radioligand therapy. This is, of course, a very flawed approach, but it's the best I can do to address this topic. In PSMA-4, you see the response rates. They appear somewhat better than the comparison to preside in a similar patient population with higher PSA response rates, slightly higher objective response rates. Between CARD and vision, it's a much closer race. Here we see very similar effects on overall survival, RPFS, similar objective response rates, and fairly similar PSA response rates. So how to decide? Well, some have pointed to the fact that patients in vision who had liver metastases fare worse. I think it's fair to say, though, that this is a good prognostic marker, but we saw from data presented in an earlier presentation, patients with liver metastases also fare poorly when treated with chemotherapy. So therapy, this is our best opportunity to directly compare chemotherapy to PSMA RLT. These are patients who were selected to respond well to PSMA RLT with higher thresholds for PSMA PET imaging, and then the exclusion of patients with discordant disease by FDG PET. There's a modest benefit on RPFS with a hazard ratio of 0.63 in favor of PSMA lutetium. There were also higher PSA response rates, and notably that difference in favor of PSMA lutetium was greater in patients with a higher PSMA SUV mean. So easy, right? Just choose the patients with a high SUV mean. Not so fast. There's no survival benefit reported in therapy, recognizing it's underpowered for overall survival, but there's really no hint of a survival benefit. And I don't think this has been shown yet, but there's also no difference in overall survival, even among patients with a higher PSMA SUV mean. And in fact, the higher curve there is cabazitaxel. And as a previous speaker also commented on, the screen failures in therapy do very poorly, presumably with best standard of care, I presume included mostly cabazitaxel. And this group of patients is likely overrepresented with patients with aggressive variant prostate cancer who would do poorly with any therapy. So in summary, the optimal sequencing of chemotherapy in PSMA RLT is undefined. Cross-trial comparisons suggest that lutetium PSMA 617 may have a higher PSA response rate than docetaxel for patients with mCRPC and a prior ARPI. Cross-trial comparisons also suggest that PSMA RLT and cabazitaxel have similar efficacy for patients with mCRPC, prior ARPI, and prior docetaxel. The therapy study suggests that PSMA lutetium 617 has improved PSA response rate and RPFS compared to cabazitaxel, but no difference in overall survival. So what to do? I'll just jump down to really the bottom point there. So for chemotherapy-eligible patients who meet imaging criteria for PSMA RLT, meaning candidates for either therapy, there are no evidence-based criteria to inform sequencing. Liver metastases and low SUV mean are prognostic, but probably not predictive of a differential survival benefit for chemotherapy and PSMA RLT. Thank you. So this was the view from Western New York a Monday afternoon a few weeks ago. So for all of you, I hope in 2026 you can be in Spain to witness a similar phenomenon that will occur then. Thanks.
Wonderful, thank you. Now I'd like to introduce Mike Hofman, who's going to talk about alternative PSMA ligands for diagnostics and treatment. Are they interchangeable?
Thanks, Louise. And thank you to Silke and Aurelius and all the panel members for organising such a fantastic conference where we can talk about some of the nuances that we see in daily practice that we don't have phase 3 trials for. And when I come to conferences, one of the things I really miss is Melbourne coffee. And, you know, there's a bit of a difference in the coffee as you travel around the world, and I really miss my home brew. But in the field of PET radiopharmaceuticals and therapies, it's not just a matter of taste, but also precision and efficacy. So let's explore the differences between our radioligands. Are they interchangeable, or are we brewing up a recipe for unexpected outcomes? So we're fortunate to have a library of PSMA PET tracers for imaging. And the most experience is with the two tracers on the left, which is gallium PSMA-11, over a decade of experience, and DCF-PYL, probably about 8 years of experience. And these are really interchangeable. We use both in our centres in quite high volume, and we just see very similar uptake. We've done an intra-patient comparison where we've looked at the physiologic uptake in normal organs, and it's really the same. The liver uptake's the same, the parotid uptake's the same, and we're very happy really to interchange these. We now have a new FDA-approved tracer, RH-PSMA-7, and I don't have personal experience, but the literature looks very similar. It looks like it's got similar liver uptake to the other FDA-approved ligands, but PSMA-1007 on the right, which I think you're still maybe using, Silky, has quite a different biodistribution with much higher liver uptake. And this is relevant because we use the liver threshold to select patients for radioligand therapy. In Australia, our reimbursement for PSMA PET-CT is actually agnostic. This is a graph of actual reimbursement per month, and we're now doing about 10,000 studies in Australia per year that are reimbursed, and many more that patients are paying for that sit outside the reimbursed spectrum. And the provider can choose. They can use any PSMA ligand they want. So it really democratises choice. Some people choose to use gallium-68 because it's very flexible. You can have your gallium generator on site and make the tracer whenever you need it. You don't need to order it and get it shipped to you. And you can also make gallium on a cyclotron now. And in fact, in Darwin, which is quite a remote site, this is how they now do their PSMA PET scan. So it's very flexible. Now here are three phantoms. One is filled with fluorine-18, one is filled with gallium, and one is filled with copper-64. And this is really an advertorial for the APCCC meeting next year on diagnostics. We're going to deep dive into some real nuances like this, at least I hope. So which one is best? Does anyone have a vote? Can we tell the differences? Well, actually, the gallium is over here. It's in the middle, and it's slightly inferior in a phantom. But I think in clinical practice, this is not really seen. We've also got differences between PET scanners. So on a digital PET scanner, you can resolve this 6mm nodule in a phantom better than on an old-fashioned analogue PET scan. So our technology matters, not just the tracer. And our technology is outpacing the evidence base. We simply can't do trials of all these things. And even for bone scanning, we've got two agents in use in different places in the world, MDP and HDP. We rarely discuss that. We can choose between SPECT or SPECT-CT. So let's not be diagnostic hypocrites and focus too much on some of the minor differences between tracers when there are so many factors. What about differences in tumour uptake? Well, we can compare all the different studies, but in fact, none of these studies compare these ligands with each other's. They all compare the ligand with a CT and bone scan. So we don't actually know how these tracers perform head-to-head. So I asked the community, if we're doing the next generation PSMA ligand, let's not do a study comparing to CT bone scan, but let's compare to an existing FDA-approved PSMA ligand to see, is it superior? Now, we do great studies in Australia, and this is a really great study. This is one of the few head-to-head comparison studies done by David Patterson, one of our ex-fellows who's now in Brisbane. Head-to-head gallium PSMA-11 and PSMA-1007. He did this study because he wanted to show that PSMA-1007 was as good or better. He did show that there was low bladder uptake, and this allowed the prostate to be visualised with better accuracy. But he also saw this benign bone uptake. Here's a sternal focus, which hadn't changed over 3 years. This is a benign focus. And in fact, what happens with this tracer is the fluorine-18 seems to dissociate after injection. And we know that sodium fluoride is a bone scan imaging agent. So you get some benign bone uptake. And this occurred in 50% of patients. And it's really quite high. And the SUV max of some of these bone lesions was an average of 6. which is quite high. You can decrease this with reader experience, but it's quite challenging, and this is particularly difficult for staging or oligometastatic disease. And I can tell you, Dr. Patterson has since abandoned use of PSMA 1007 in his centre and gone back to gallium because of this problem with benign bone uptake. Now, therapy. This is even more challenging. Are the ligands interchangeable? Well, we have less choice. We've got really two main competitors, PSMA INT and PSMA 617. And if we compare the PSMA 11 for imaging, INT 617, they actually all have the identical chemical structure for the binding motif. Where they differ is the chelator, this molecule that bonds to the radionuclide. And only one of these is FDA approved, which is PSMA 617, and INT not currently FDA approved. We have lots of experience with both. There's more literature for 617, but actually use of INT slightly predated 617, so we have over a decade of experience with both. This is really important. For INT, there is a homebrew in many centres, which can be rather cheap and advantageous, particularly in some geographic locations. So we have extensive off-trial use, which is not represented in the literature. I'm not going to go through all these trials, or the SPLASH trial, which uses a lower dose, but we do have some meta-analyses which try to summarise all this data, and they show that there's no significant difference in PSA response between INT and 617, and there doesn't seem to be a difference in toxicity. Our own Australian government, Health Technology Assessment Committee, has looked at this, and they've said that they're equivalent in safety and efficacy. They use the word radio equivalent, and they acknowledge that there is a limitation in evidence base, but they accepted that the two products appear to be mutually non-inferior for patient outcomes. So, these molecules are not magic. They're essentially a radiation delivery device. We see actually quite a narrow dose variation for normal organs, but quite a high variation for tumour, depending on your intensity of uptake, and we see a dose-response relationship. So we should consider whether lutetium PSMA, is it a drug or is it a type of radiotherapy? And it's a little bit of a mixture of both. In the radiotherapy model, we use dosimetry to define our dose limits, to perhaps define dose to tumour. In our drug model, we don't need this. We simply escalate the dose and observe acute toxicities and response. And it sits somewhere in the middle. I think it sits slightly more towards the radiotherapy model. And we do have comparative dosimetry data between INT and 617, and they show really that they're very, very similar. There is slightly higher renal dose with INT, but this doesn't seem to be clinically significant, and the tumour doses seem to be comparable, but we do have a large inter-patient variability. In the previous APCCC meeting, 3/4 of the people voted that 617 data cannot be extrapolated to INT. In a survey that we were part of at 95 theranostic centres, we can see that both are in widespread use. But the choice between INT and 617, I don't think it's as big as the choice of should you treat this patient. Patient selection is critical, and here we see the value of FDG PET. There is a bone lesion, which you can't see on the CT, can't see on the PSMA PET. It's very FDG positive. It makes these invisible bone lesions visible. So please don't treat blindly. I'd like to invite Professor Hope to come to Peter Mac to observe the benefits of using FDG. I think since he doesn't use it, he doesn't know the benefits, but he reaches a conclusion that we shouldn't do it. But I think this is a patient that you could determine upfront is not likely to benefit from treatment. You don't need to try 2 cycles. We can see it upfront. So as we advance, we've got new ligands. We can go from small molecules to antibodies. And, you know, a few years ago, I think I decided that at least for the moment, the peptides seem to have won. We started with antibodies targeting J591, and we could see that these were significantly inferior. With the small molecules, we get higher tumour uptake, so better tumour targeting, and we get more rapid clearance, which means less side effects. They're cheaper. But we have a whole range of new molecules and labels to alphas, and we need prospective high-quality data. So in summary, the best PSMA radiotracer is probably the one you can access PSMA 11 and DCF-PYL are both equivalent. RH7 looks very, very similar, but we've got less experience. But beware with PSMA 1007, it is different, and this benign bone uptake is quite problematic. PSMA 617 and INT seem radio equivalent. We've got the luxury of a decade of clinical experience there. The peptides win, at least for the moment, and don't forget that reader experience, patient selection, all these things really matter. Thank you.
Thank you, Michael. Our final speaker in this session is Stefano Fanti. Stefano will discuss how to utilize presence or absence of CT findings on a PSMA PET CT.
Good morning, everybody. Happy to be here to give the trolley lecture. And first of all, it's a true honor to be here again to give a lecture. We will have time to congratulate you, but my sincere congratulations for making such an incredible, fantastic event. It's truly the event on prostate, really great. So these are my disclosure. As I used to say, the main disclosure is that I'm proudly a nuclear medicine physician. And when I read the title that Silke and Aurelius provided to me, that was how to use the presence or absence of CT findings on PSMA PET-CT, I got sort of memories. And essentially, it was a déjà vu, because 2 years ago, on that same stage, I was asked to talk about how to interpret and confirm lesion positive on PSMA and no correlate on CT. So the first conclusion was that my talk 2 years ago should not have been very brilliant, because indeed, I haven't convinced many people. Well, that talk was indeed based on philosophy, and essentially philosophy of science. So I took the logical point of view. That's to say, if you conclude something on the basis of good evidence, you cannot use something else obtained with less good evidence in order to confirm something. This is a hierarchy of the truth, which is absolutely applicable to medicine. And we have some scientific data about the fact that PSMA PET-CT has higher detection rate, higher sensitivity than any other imaging modalities, either in nuclear medicine or outside nuclear medicine. But nonetheless, again, memories. Last year, I've been invited at several meetings, including Karim here and others, and they all asked me to talk about findings on PSMA PET are reliable. So, in those cases, I took sort of political talk. I said, hey guys, there have been other specialists, especially, hematologists. The hematologists have accepted the incorporation of FDG PET into guidelines without the need of CT confirmation. And the same was done by thoracic surgeon. So it was a sort of declaration that maybe you are not a believer. And, right now we have seen that even Pete Oster has become a believer. But nonetheless, the usual suspect. So what I said, no, it's all about you. It's you that you don't trust me. The problem is your capability of trusting me. And I wonder, how can you not trust such beautiful images? You see the whole body. You see the hot spot. You see the met. How is it possible you don't trust me? Okay. There's an elephant in the room. That's super clear. There is a problem. There is an elephant in the room. And that was confirmed 2 days ago. Question number 2. You see, in the majority of patients, clinical high risk, PSMA PET positive without a correlate, what would you do? 55% say, okay, I want correlative conventional imaging. I'm sorry for those 58 estimate colleagues. You are wrong, because there's no logic. There's no logic there. There's absolutely no logic. But again, there is an elephant in the room. Let's address it. That's the typical example. A patient studied for staging, high risk, faint uptake within a rib. Is that a MET? That's the main question. And I'm sorry, I will show you a couple of anecdotal cases. It's anecdotal, but it's still very simplificative of what it happens on real life. That's a patient referred to us a couple of months ago. Studied at another institution. Michael just covered so brilliantly and exhaustively the difference between tracer. He was studied with fluorinated PSMA 1007. So it's a bit blurred, noisy, many spots, and 2 of them were reported as metastasis. So completely different approach to the patient. No CT counterpart. 2 spots in the rib and in the pelvic bone. So what would he do? Well, we did something we don't like to do, because it's a cost, it's exposure of the patient, but we repeated the scan with gallium PSMA 11. And as you can see, there's no uptake. So everybody was happy. The patient was happy. Referring physician was happy. Discharge at M0, all good. This is very well known in the literature. As again, Michael just said, 5 times higher non-specific bone uptake, so 5 times more likely to have false positive. Okay, you can increase your capability, expertise, but nonetheless, it remains a major problem. So, you know who we have to blame? The molecule, the radiopharmacist. The problem is the molecule. You have to choose wisely. That's very understandable by the psychological point of view. It's something we do every day. It's his fault. It's her fault. It's not my fault. Okay, another example. A couple of weeks ago, again, staging high-risk patient, referred at our institution with our beloved gallium PSMA 11. And you see, hotspot in the rib reported as M+. And again, the literature is telling you it's not only about fluorinated 1007. Also, gallium PSMA could have non-specific bone uptake, especially when its faint uptake, in the very majority of cases, is not a metastasis. So I have to admit, spoiler alert, it's the nuclear medicine people who's guilty. It's our fault. You have to blame us when we make this. So the message is very, very simple, and it's mostly for the nuclear medicine community. We don't have to call faint uptake as M+. Such uptake without CT, and CT could never be able to confirm that. So we don't have to follow pathways which are non-existing. And in summary, requiring CT positivity for decision on M1 or M0 is absolutely non-logical. And in the case that I already showed to you, it was reported as M0. We performed a follow-up PET, and there was no longer any uptake in the rib. So, coming to some conclusion and quoting my favorite philosopher, and remember to all of you that Spider-Man was a nuclear medicine guy because the superpower came from radioactivity inside him. We had PSMA PET. It's been game changer. It really made our life so much better. We were invited to come here. We had success patients attending MDT. But with great power comes great responsibility. So it's our responsibility to choose the very best tracer. Not necessarily the only one available, but you can push to have the best one available. This is something we have to do. CT confirmation is clearly useful. We have the CT counterpart of the PET-CT, we can use it, but it's not necessary. In my view, it's necessary discussion at MDT. It's much more important. And again, sorry for repeating myself, don't call faint uptake as M+. Now, there are some open questions. Agreed consensus on how to report. Can just mention the SPARC initiative. That will be very important. The impact of imaging on patient management, but not only change in management, but to have an impact on major clinical, like overall survival or whatsoever, a major objective. Establish cross-specialty interaction. Integrate the use of all the imaging and non-imaging approach to diagnosis. So, some problems. Diagnosis is clearly getting more complex. We have blood tests, biomarker, imaging, and so on. The importance of prognostication as compared to identification, and many unsolved challenges. And for all these reasons, Ken Herrmann, with my little help, and the great help of Silke and Aurelius, decided to organize APCCC Diagnostics next year. So I'm inviting you to come next year here in Lugano to see if we can address some of those questions. Thank you very much for your attention.
So just any questions from the audience?
Francesco Sangodolce from Barcelona. I really enjoy the session. And the immediate question that I have is to Stefano, about you are the distinguished panelist, is about, would you define what is the faint uptake for us to understand how would you define this eventual false positive? Thanks.
It's clearly about the intensity. And as said, it's absolutely everything but easy. That's why we have this SPARC initiative to define, because faint is absolutely a subjective description. But you cannot even pretend there is an absolute cutoff that could be applied in Melbourne and in Bologna. So it's about to have a reference that could be the liver. It could be different tracer by tracer. It could be related to the expertise. But what is clear to me is that there is a lot of psychological pressure when you report these scans. You have the pressure of the referring clinicians, especially BCR, for example, the pressure of the patients, your personal pressure to write something significant in the report. That's what we have to avoid, to please the patient, to please the referring physician, and to call what is absolutely very faint, so let's say SUV4, as a metastasis, because that will impact deeply on the patient management.
And will be actually a whole body MRI space to eventually have a reflection test instead of the CT scan, as you mentioned?
Honestly, I have no personal experience with that. Could be. But don't forget that, for example, ribs are not so easy to study with whole body MRI.
Thank you.
Janine?
So thank you for that excellent presentations from all the presenters. So one is a comment and then two questions. The comment. I think it's fair to say that PET scans and radioligand therapies are here to stay in this disease, which is terribly exciting. But as we embrace it with abandon, which is what we're doing in the context of clinical application and clinical trials, I would advocate that we make sure we understand the subset of patients that are coming off treatment very, very carefully, in particular if they're then not able to get other systemic therapies that are life-prolonging. And my concern is that as we capture hematological toxicities, and both Tom and Louise made a similar comment about taking patients off study early and prior to perhaps bone marrow failure, it's just an observation in the clinic, having used these therapies for a number of years now, that there is a small subset of patients that progress very, very rapidly on the back of this therapy and may not be able to access another line of systemic therapy. So I would just advocate, none of these things are in phase 3 protocols, and I would advocate, as we do clinical trials, this aspect of the data is captured and is generated for the broader community. So that was the comment. The question to the nuclear med physicians on the panel is, can we define systematically a subset of patients that benefit from retreatment? And we've done this in ovarian cancer in an arbitrary way of 6 months of response or benefit, but it would be useful to define it in a systematic manner, again, for the purposes of capturing data and understanding who benefits most from retreatment, because we do know that patients like radioligand therapy, and it's very well tolerated, so often you'll have a patient who wants more of the same because the first time round it was highly beneficial. And linked to that question is, if we are retreating, is there a maximal number of cycles where we should then stop and say, time to move on to something else? And again, reflecting my own anecdotal experience of a number of patients that have had multiple cycles of treatment and have had renal toxicities from which they've not recovered. And then final question is, when are we going to get to the point where there is an automated way of defining tumor volume so that we can start personalizing the dose and the schedule that patients get treated with? Thank you.
So really appreciate your perspective and your question. So maybe Thomas, do you want to take the question of retreatment?
Sure, retreatment. So I learn from Professor Emmett all the time about instituting delays. So we do quite a lot of delaying treatment based on good responses. And so we come back and retreat most of those patients depending on what they look like. Depending on their length of delay, we do a repeat PSMA PET. And the asking for rules of who you should retreat, I think, is a little bit difficult. It depends a lot on what prior therapies they had, what their PSMA PET looks like at time of reprogression, how they responded initially. All those things have to be taken together. But I think it's important to realize maybe the general statement would be that patients do benefit from retreatment, and that should be an option that we should consider. In the United States, I think it's not utilized because of this label the FDA has. This up to 6 cycles is a little bit of an odd label. There's, chemo doesn't have that in the label, et cetera. So I think it's just important for us to realize that retreatment can be therapeutically beneficial for patients, and we should keep it in our armamentarium to treat patients. We could sit down and create things that would suggest patients who would be good or good candidates for retreatment, but I don't think I would have the set of rules I would follow at the moment.
Just answering the quantitation question, we would love that. We need companies to work with us to get automated quantitation. And I think there's a lot of people in the field actively working on that now.
And we do retreatment actually quite frequently in patients who respond, right? And we actually do this neuroendocrine tumors for a much longer time. And that we really achieve significant renal failure in these patients is not very frequent. We have seen this much more frequent actually with Yttrium 90 in the good old days 20 years ago.
Thank you.
Yeah, thank you. Levent Türkeri from Istanbul. If you go to the basics and look at the mechanism of radioligand treatment, it causes widespread DNA damage. So it's the perfect scene for augmented synthetic lethality with the PARP inhibitors. My question to any one of the panel members, if they have any experience or observation, if that is the case, when you use in combination or in sequence radioligand treatment with a PARP inhibitor, they cause or they provide additional benefit.
I think you should have a chat to Dr. Shanine Sandhu, who's just sat down, who's running the LUPARP trial, which is olaparib in conjunction with lutetium PSMA.
I can comment on it since we're running the LUPARP trial. We've completed, I think it's been presented at ESMO by Dr. Sandhu. It seems very well tolerated and the response rates look promising. So I think it's a nice combination to take forward. We were concerned that there would be a lot of toxicity, but it's an incredibly well tolerated combination. We've used a pulsed PARP inhibitor with each cycle up to date. But there are other alternatives. We're also running a trial called LUCAB, which Louise is going to start as well, where we're combining with carbazitaxel at the same time, and taxane chemotherapies are also very good radiosensitizers. So I think this warrants exploration as well, and carbazitaxel is a good drug, as we could see in the control arm of the therapy study, and there might be a lot of benefit to combining rather than sequencing.
And there's a lot of preclinical data for ATM and ATR inhibitors, and for this it's maybe not surprising that AZ recently entered the field.
Dan.
Yeah, just comment on that. PARP is actually a pretty weak radiosensitizer. We've used it with external beam in many trials, right? It inhibits base excision repair, so it's not necessarily causing synthetic lethality. But the question is actually, Dr. Hofman, I agree that I think lutetium and these radionuclide therapies are far more like radiation therapy than they are like drugs, but they're treated, and I think the regulatory pathway is they're handled like drugs. Unfortunately, in my opinion. And so when we look at, 40 years ago with external beam radiation, giving split courses of radiation with weeks in between, the outcomes are far inferior than to continuously, they talk about the 4 R's of radiobiology to be able to actually eliminate a tumor. But the way these trials are done is they're giving, whether they're at 4-week intervals or 6-week, depending on the drug, is there really continuous DNA double-strand breaks at the target, or is there an interval where it's really getting very minimal dose? And so how do we get an actual, treat this like radiation therapy? And also the radiation therapy, we would never do something like a drug trial where you're trying to get maximum tolerated dose. We treat based on organs at risk, dosimetry as well as maximal tumor dose to be able to actually eliminate a tumor. So what is the dose that will eliminate a tumor with lutetium PSMA?
I think it's not true that the regulators consider it as a drug. Certainly the FDA takes into account this, theoretical dose limit to the kidneys of around 20 to 25 gray, and it's determined the doses that are used in a lot of our studies, and we've argued strongly against that, extrapolating doses from external beam to radioligand therapy. So there's a lot of work to do in defining the optimal doses, and we haven't got there yet.
But there's a packet, when you get Pluvicto, it is a fixed activity, and we are giving effectively, I know we use the terms dose and activity kind of interchangeably here, but we're giving that whether someone has 2 bone mets or 400 bone mets. We're giving that same amount of activity, and obviously the dose is different. That's very different than if this was external beam radiation therapy.
We've got a lot of work to do. So we need to look at fractionation. We need to look at alternating the dose based on volume. We need to know what dose we need to deliver in order to get good cell death. We don't know any of that. That's all something that needs to be figured out.
Dan, you actually gave yourself the right answer. You said you have 40 years of experience. We have like 5 years of experience. So we need to make the 35 years up. So I fully agree with Louise.
So I share in the excitement and admiration for all of the work that has been done. Just 2 very quick comments. One is, I say this with all respect, but anecdotes do not constitute data, and sometimes we are, we counter data with anecdotes, and that generally should not work. The other comment is we get conventional imaging because conventional imaging, or the biomarkers that were used to demonstrate survival benefits in the prospective trials that were done, that have informed our standards of care. And so I think that's the reason. Nobody doubts the sensitivity of PSMA imaging. It's a question of what do we know about how to treat the disease that's detected on PSMA PET. But my question's for Dr. Smith. Do you have a sense that there are some people whose disease might be accelerated by radioligand therapy?
To date, no, but I have to acknowledge that I don't have the vast experience of some of my colleagues in the audience, like Shanine. But there certainly are patients who, I think a challenging part of what we do here, right, is that we don't know in advance who will respond and who will progress. And you can take 2 patients whose clinical histories, prior therapies, and PSMA PET imaging are nearly identical, and they'll have very different outcomes. And I think this is a major unmet need to understand response and resistance.
Well, I ask you that question because generally these are people that will not go back to nuclear medicine, right? They come back to your medical oncology clinic and
Well, they never, in our practice, in our model of care, they never leave us. So the medical oncologists manage the patients. We work closely with our nuclear medicine colleagues. And in my presentation, I was asked a kind of a challenging question, to make a case. To follow up on, it's really, Shanine Sandhu made a beautiful point here, and that is, in my practice, that last category of patient, if the patient's a good candidate for either therapy, I would prefer to give him chemotherapy first, based on available information. It is a conversation with the patient, and I think it's really, because if they're going to get both, the question is, what's the sequence, right? It's not, and we don't have evidence that giving PSMA RLT prior to chemotherapy is superior. My preference is generally to give chemotherapy for patients who are willing to take it, in part because I think it gives them more opportunities. If there were better ways to know in advance, if we had better predictive markers of the differential effect of those 2 agents, then we'd be in a much better position to make those decisions.
No, curious sort of more about the biology that might underlie this. This is a small subset of patients, and this is a sort of a perception, and I don't know if the nuclear medicine physicians have seen.
I'd like to comment. Sometimes when we get some patients for radioligand therapy, it's after chemotherapy, it's patients who really have no options, and they're often on a rocket. Sometimes you can see them turn up for screening with a PSA of 2,000, and by the time they come, they've got a PSMA of 7,000. And they are heading for marrow failure extremely fast. So it can be difficult sometimes to know. I think we need to look in the trials extremely carefully. I gave an anecdote a couple of days ago. I was doing my first trial, and I got a phone call from a very irate oncologist who accused me of killing their patient with marrow failure. And I was really depressed. I was on a goat track in Italy. And half an hour later, I realized we hadn't actually injected that patient yet. So you have to really look at the data carefully to make sure it's not anecdotal.
No, right. So again, that's why, is there a sense, I've talked to some of my other medical oncology colleagues, and there's a sense in people that have not had prior chemotherapy even, that a small portion, clearly radioligand therapy works, and it's a fantastic drug for many, many people. That's not what I'm asking. But there do seem, or the thought is that there's a small subset of people where it looks almost like it's accelerated. I'm just wondering about the biology underlying that, whether that's something that you've seen.
I think to add, imaging is not just a biomarker, as you started with. It is actually an extension of like a clinical examination. So for example, if you want to obtain a biopsy in your patient with metastatic disease, maybe to look for a DNA repair mutation, if you use conventional imaging, you'll just blindly pick one of the 50 metastases, and then you'll use that specimen to maybe determine your patient's management. But if you do PSMA and an FDG, and then biopsy the more dedifferentiated disease, you may get a more reliable truth for that patient. So it's kind of like doing a clinical examination and then finding where you're going to get your reliable biomarker from.
Okay, 2 final questions. We'll ask for short questions, short answers, Niraj, and then Oliver.
So maybe, Louise, fantastic talk, and maybe you or Oliver both can answer this question. I was intrigued by your comment on, and again, not questioning your experience, do not reduce the dose of like lutetium-177 radioligand therapy in the first dose, at the first dose. Don't reduce it. So what about those patients who are really not meeting the criteria for vision trial, for example, low platelet count, borderline, they have received chemotherapy already? I'm often tempted to reduce the dose, just to keep it safe, control the disease, and then increase the dose with the next dose. So where do you reduce the dose? Which circumstance, in which patients you reduce the dose?
That was such a difficult question for me, because I really, I like to give full dose, or if I think it's not worth giving, then I don't. So I would reduce dose in patients who are following a few lines of treatment if I really thought it was toxicity related to lutetium, not progression. And perhaps, Oliver, do you want to?
I think that's a very complex one, and a lot of the problems that we have are really related to the cancer, and we need to treat the cancer in an aggressive manner. The alternatives that the patient may face is less than optimal therapy. So I have a tendency to kind of think full doses in almost all circumstances, unless there's just a clear danger signal. But
Oliver,
that's just me.
Last question is yours.
Last question. Gosh, I have a short question, but not a short answer. I'm really concerned that through dosimetry and the belief in dosimetry, we're not optimally dosing these patients. And the question is, how do we get to optimal dosing when we have limitations imposed by the regulators that may not be reasonable? So that's a really hard question, but I'd love to hear just a brief answer. How do we get to optimal dosing? Because I don't think what we're doing today is really the best. Short answer, please.
I'll just take a first stab. So, we spent through a CTPM in the United States on neuroendocrine tumor 2 years trying to design a trial to demonstrate that personalized dosimetry would improve patient outcomes. And I would say, I don't even know how to design that trial, frankly, at this moment in time. We don't know the relationship between dose and response well enough. We don't know I agree that it's clearly wrong that we're giving all patients unit doses, right? But I wouldn't know how to begin to say what is that dose so we could even test in a trial setting. So right now we're in the setting of the next 35 years learning about this, trying to understand where it is, how patients respond, what's predicting response. And the problem with dosimetry is it's probably 1/3 of the issue. The other 2/3 is radiation sensitivity. So we don't even understand that aspect of it. So to go to a point where I don't think it's the FDA's issue. I don't think we know as a field. I wouldn't even know how to go to the FDA to propose a trial that would show personalized dosimetry would improve outcome.
I think the problem right here, guys, is that all of you, as well as these, people asking questions, call this dose. Going back to the drug point, this is not dose.
I fully agree with you.
This is activity.
The problem is
it's the dose to the tumor, and so as long as you keep referencing this as dose, you're going to stay 40 years behind.
I mean, no, this is an absolutely fair point that we are not really accurate. It's a language problem. Yeah. So activity and dose is really separate. I fully agree with you. The main problem is, and Oliver, you know about the vision trial, there is a sub-study, dosimetry. we only look at the doses in the normal organs. It was like pulling teeth to get the sponsor into looking into the tumor dose. I still haven't seen the final results. And this is where we need to start off. Then we do understand the difference between activity and dose, believe me.
We need to reimagine dosimetry. We need to take it back and do it right at the beginning when we're doing the PET. We need to look at tumour volume. We need to look at radiation sensitivity. We need to look at genetics. There's a lot of work in figuring out how we optimise what we should be giving to patients.
I really hope some of that will be discussed next year. So Ken, Stefano, you have to work hard on these topics, I guess.
And it's really good that we all come together at meetings like this and have a common understanding of what we are talking about. Clearly, there are some misconceptions, misunderstandings, and we need to bring these communities together. So we have some final questions. We will stop at 12:15 on time, definitely, but we wanted to share some of the voting results of APCCC 2024. And this is about chemotherapy-fit patients with mCRPC who meet relevant PET criteria and have received 1 line of RP treatment, no chemotherapy. And the question was, what is your preferred treatment option, assuming all options are readily available and there are no actionable molecular alterations? And the big yellow part of the pie is docetaxel. The green part is lutetium PSMA in patients that are asymptomatic. If they are symptomatic, 82% voted for chemotherapy and 17% for radioligand therapy. This is like first-line CRPC or after ARPI treatment. And the subsequent question, and we voted on that before, and we just reached consensus in 2022, and now we have a follow-up voting on this. The same situation, but the patients have now received an endocrine option, RP, and 1 line of taxane-based therapy. And you see now a very strong consensus, 96% for radioligand therapy in this situation. Can we get short comments from the panel? I don't know, I start with Louise.
No, I think it's very logical, and we're waiting for PSMA-4 results. And I think Michael gave a great response to that yesterday. We're waiting for PSMA-4, but we've definitely got vision and therapy results, and I think this is really appropriate.
And we did specify chemo-fit patients, so it's not the frail older patient who is not fit for chemo anyway. These are chemo-fit patients. Michael?
Yeah, I'd say it can be challenging for patients to go from chemotherapy to chemotherapy. So my preferred approach, I voted with the majority for all of these questions. I would prefer to sequence it docetaxel, PSMA, RLT, cabazitaxel for patients who are candidates for all of those treatments.
Yeah, I think the main message here is not to forget cabazitaxel as an option after lutetium. This is not instead of cabazitaxel, it's an additional option. It's got a very different mechanism of action. And, we don't cure anyone with lutetium, so you always need to keep in mind if you're fit for another treatment, whether it's a PARP inhibitor, cabazitaxel, or something else, when should I stop and move on to the next treatment?
And we asked also about the selection, and that's quite interesting. So we see some people who really voted like Michael and some like Tom. So you see here the question was, in the majority of patients that you evaluate for lutetium PSMA therapy, what are you using? And in green, 24% people would really do PSMA PET, FDG, and an FDG PET. In blue, you see here a third of the panelists would do PSMA PET and bone scan. Sorry, Stefano, I know you don't like that, like in the vision study. And then 43% would do a PSMA PET, and then only add the FDG PET for equivocal cases. And interestingly, no one voted for no PSMA PET imaging needed. So I would, Tom, like you to comment on that.
I think it's a reasonable approach. The only thing I'd push back here is this idea of doing bone scans. I didn't really address that, but I hope no one uses a bone scan to screen patients for PSMA radioligand therapy. I think the question then comes down to how often do you use FDG PET in addition to PSMA PET? And there's one end of the spectrum, maybe I'm on the other end of the spectrum. I think I'm more of an FDG PET selectively rather than in all patients. But I think this is reasonable, and this is where the field is in general.
I heard Ken talk about one imaging that includes PET, FDG, and PSMA in one go.
We're not there yet. We do this we do this in a one-day protocol. But I'm actually also very similar to Tom, to be honest. In an academic setting where resources don't play a role, I'm happy to do both. But I would stop from proclaiming that everyone should do this in the real-world setting.
I'll add one thing that's, one of the research studies we're doing now is a whole body MRI plus PSMA PET, and the whole body diffusion weighted imaging can be in essence a replacement of your FDG PET. And so in a single study, if your institution's insane enough to spend the money on a PET MRI, you can do a single study and get a whole body DWI plus a PSMA. That's more academic, but it could be cool in the future.
FDG is widely available. So it's available everywhere. It's used as a standard of care. So I think we shouldn't forget it. If you vote for option 4, which nobody did, no PSMA PET. In fact, in PSMA 4, almost everyone was suitable after a PSMA PET, so it didn't actually add a lot. The FDG actually adds a lot more. And if we take the biomarker perspective, if you want to correlate with overall survival, actually the metabolic tumour volume in the therapy study was the strongest predictor of survival, stronger than any prognostic factor. How you use that to influence patient care is nuanced, but at least you can then put the patient know that they're not going to do well. It may make you choose a more intensified therapy. It may make you monitor treatment more carefully and switch to another treatment more rapidly. So I think we should do more studies on FDG PET. It's a widely available, simple test, huge value.
Michael, just the paper Tom showed was showing that only 3% are different from using a contrast-enhanced CT in PSMA and an independent read in addition to FDG PET. Would the 3% justify the costs?
I don't believe that data. I don't think it's correct.
And I guess, because you have seen that most people, the panelists, would use the lutetium in MCRPC after 2 lines of therapy. This is probably also why they speak about the eligibility here.
So in the therapy study, FDG added about 15 to 20%, so much more than 3%.
Yeah.
So when we excluded roughly 30% in the therapy study, around 10% was PSMA and around 20% was FDG.
And it's good to hear that whole body MRI is coming back. I don't know whether you remember, Stefano, in 2015, I think you had a debate with Anwar on whether to do a whole body MRI or PET, because PET was really just a new kid on the block, and Anwar was very much promoting whole body MRI diffusion. He's online. He couldn't make it to be here, but he would definitely have something to say.
And we will invite him for 2024, I think.
Yeah,
25, sorry.
We're missing Anwar.
So we come to the monitoring. 2 questions on whether or not you recommend monitoring by imaging in the majority of patients on now radioligand therapy treatment in the absence of clinical progression, of course. And you see here 70% of the panel members voted yes in the majority of patients. 22 would only do it in selected patients, and 8% did not vote for imaging as a monitoring modality in patients on treatment. I don't know, we may vote differently after today's talk. And the subsequent question is what imaging to use, or what the panel members would use as response monitoring. Conventional imaging, 20%, PSMA PET, but without the contrast-enhanced CT scan, 25%, a diagnostic PSMA PET, including the CT with contrast, 41%, and SPECT CT, Louise, only 14%.
Certainly something we need to work on. SPECT CT can be undertaken with any bone scan camera. So it's widely available. It can be done instantly after each injection. So we can do it frequently during lutetium PSMA therapy. I think it's an underutilized tool.
Can you work on the presentation of these specs? Because to me, they are difficult to interpret. They look a bit hazy, not very detailed. So I don't feel comfortable looking at them, and my patients also don't like it.
Yeah, we can definitely work on that. That one bottom push for quantitation transforms SPECT into something where you've got absolute tumour volume. It's reproducible. You can look at intensity. You can look at new sites. It's where we need to go.
Yeah, and I have to admit, Stefan, I think you are a bit right. We don't trust you 100%. So we like to look at the pictures on our own and not just having, someone writing it's everything fine. So I think this is also some education from your side for the clinicians to understand the SPECTs and maybe even also the PETs better, because we have a lot of experience with FDG PET. We have much less experience with PSMA PET. That's growing, but even less with SPECTs.
I think you didn't have option 4.5 there, which would be just a planar image. So after lutetium, you can do a 2D scan, planar, or you can do a SPECT CT. And I suspect maybe the blurry images you see are planar 2D images.
I agree.
And when you do SPECT CT, you actually get PET-like images nowadays, and they're really easy to interpret and even better with quantification.
And the point that you mentioned about interaction is exactly what I emphasized about the need to discuss all the images at the MDT, which is a sort of mutual help and advantage, because we can get from you information and you can get a little bit of free training, and patients will probably benefit from that, because in many cases, the pending or the difficult to interpret findings could be solved with interaction.
And I mean, you've done amazing with PET imaging and these color codes. This was one reason why whole body MRI never made it, because you clearly,
CT looks the same. So it looks the same, with the same colors. It can look really beautiful. We need to train all of our centers in how to do that.
Exactly.
I can add one more comment.
Okay,
6 SPECT CTs are cheaper than 1 PSMA PET in the United States. So that's the first point I want to make. Second thing, SPECT you can do every cycle, PET is once, right? And you don't know when that change in management is going to happen. And we talk so much about prognostic, blah, blah, blah. I want to know, when does imaging change what I'm going to do with that patient? That's the most important thing. And if we think about it that way, and hopefully I got the point across in my talk, we should be really focused on SPECT. If whether or not we make it pretty or not, that's a different point. Whether or not it changes the patient management is what we should focus on, and it really highlights nuke meds need to be involved in the management of these patients after each cycle.
We come to that question in reality. So here, that's the question I think you're addressing. In the majority of patients with a response, so clinically, PSA, clinically or radiological, after 4 cycles, do you recommend completion of the 6 cycles? And we had 2 settings, one with a significant remaining uptake, and the second one with no remaining uptake. And you see here, the green, so option 1 is yes in the majority of patients, so with significant remaining uptake, this was a consensus to do 2 more cycles. If there is no remaining uptake, only 18% voted for that, and 57% for no. So again, can we have some comments? Tom?
And in this one, I think the audience is doing well, right? If you have residual uptake and you're responding, you should keep treating. If you don't, now, I think the harder question is, where's that line, right? What is significant residual uptake? And then I think this 4 cycles, we're choosing 4 because vision was 4 + 2, but I think the point here is it's not just 4. You could be after cycle 2, and you could have minimal residual disease and stop treatment, or after 5. So, here we have to be less structured by what happened in clinical trials, and then we need to start to figure out, where is that minimal residual? How do you define that? Does that depend on how much volume of disease you start with, right? If you have super high volume disease, you might actually have a massive response but still have residual disease. Maybe you want to give a pause in that type of patient. So I think those things we don't yet know, but in general, I think this is very reasonable.
So in reality, in MCRPC, with all the other treatments, we do a first staging imaging after about 3 months, right? So I also agree with you, why are we waiting here double the time? So Louise, when would you do your, not in extreme cases, your first decision to continue or not? After 2 cycles, after 1 cycle, after?
I tell my patients, I'll tell them their cancer dog type after the 2nd dose. So we use the SPECT after the 2nd dose, and we use the PSA before the 3rd dose, because it sometimes takes a little while to see what's happening, to find out, what they should have, whether they should continue, whether they should stop, whether they should stop for exceptional response. I think that's a really neat time point, and we also use that in ENZA-P.
Thanks.
So we look forward to your definition of significant in the manuscript. Because we clearly didn't specify it here, but it needs more flesh to the bone.
In our manuscript, it was anything above blood pool. So if you could see something on the scan, then that was significant. But I agree with Tom, that will probably change over time, and we will end up with more nuances to nothing left.
So I guess we need your help to write that part of the manuscript. Thanks.
Janine asked about retreatment. We did also address this in a quite conservative way. Do you recommend retreatment if relevant PET criteria are met in the course of the disease of a patient who has previously responded? And we specifically said 6 cycles. After the discussion now, I'm not sure that we should have specified exactly 6. You see 12% said yes. Option 2, the blue one, is yes, but only if the response was really more than 6 months. This is arbitrary, but it's based on the ovarian cancer data. 29% would not go for retreatment at this point. Ken?
Option 2 is pretty much in line with what we do clinically. We don't have the evidence, but we like to use a cutoff of 6 months. If it's 4.5 months, of course, we discuss patients' MDT, and we would, but pretty much 55.9%, or how did you say? The audience did pretty good, and I agree there.
I should talk less here, but just remember 6 months of response after you complete 6 cycles means the patient's 13 months out from initiating radioligand therapy. The overall survival and vision in the control arms, that length of time, that's like longer already. So 6 months of disease control after, that's 6 months of no treatment, and the patient doesn't respond to it, it's actually a really long period of time. So we actually retreat in patients who progress earlier than that for sure, because that depends on the depth of response, how they do, et cetera. But I would not say if you're 4 months out and you had a good response to 6 cycles, I wouldn't retreat that patient. I think that's, in this patient population, which has, an expected OS in the vision of 15 months, you're only 2 months away from that at 13 months. I think you should be considering retreatment in patients who had clinical benefit after 6 cycles.
Another way to, maybe for the manuscript, it could be 6 months response from the beginning of treatment. It doesn't say when it's from, so it's a little bit ambiguous.
But, so what is your minimum then, Louise or Ken? So would you really treat someone who was very fast after the last injection progressing? Would you retreat a patient like that? I know the 6 months is really something from the chemotherapy field, and we are like, it's kind of this magic number, but we didn't do it for the taxanes, right? Because patients progress much faster after taxanes in prostate cancer. So is there something a minimum you would like to have to do a retreatment?
I do think that if patients had a full 6 doses and then starts to progress very rapidly and they have another available treatment, then yes, I would recommend the other available treatment, because it's obviously not holding it for a period of time. For me, that would be a couple of months.
You do the last cycle, then you do restaging. After 8 weeks, you discuss in tumor board after 10 weeks, and if at this time point the patient is already progressing, we don't treat them. Then usually we wait 8-10 weeks until next restaging, and if the patient is then significantly progressing, we don't retreat them. So in the end, we come up to 6 months anyway. The question is from where you count it. But but in the end, I hope we're going to have a retreatment study very soon, where we also have clear defined inclusion criteria, and then we understand better what is the right time to restart.